Thank you for joining Cancer Support Community Atlanta for Advanced Care Planning, facilitated by Dr. Sayed, Medical Director with Northside Hospital Palliative Care. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to Advanced Care Planning. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, to see all the free oncology support services offered virtually. As I said earlier, everyone will remain muted throughout the presentation, and we do invite you to enter questions into the program chat box, which Dr. Sayed will address during the Q&A at the end of the program. I want to welcome our presenter today. Dr. Sayed graduated from Rutgers Medical School in New Jersey. She completed her residency at Cooper University Hospital in internal medicine and later returned to fellowship for palliative and hospice care. Upon completion of her fellowship, Dr. Sayed relocated to Georgia, where she later became the System Medical Director for the Northside Hospital Palliative Care Department. Dr. Sayed consults in the inpatient setting at the three main Northside Hospital campuses, but spends the majority of her clinical hours at Northside Hospital Forsyth. Dr. Sayed is passionate about improving the quality of life of cancer patients at any stage of their disease and having honest conversations and preparing them for their disease trajectory. Dr. Sayed is an advocate for the completion of advanced directives. And with that, I want to welcome you, and I'll pass it off to you, Dr. Sayed.
Thank you. Thank you for having me. I'm sure I look so much different than the flyer because this is now our life with COVID. Most of us wear scrubs and scrub hats, when we are in the hospital. But I am so glad to be here and happy to do this presentation because I'm very passionate about improving the quality life of oncology patients. Where I did my training, both for internal medicine and for palliative care, it was part of MD Anderson Hospital, and we really focused a lot on improving the quality of our cancer patients from early stage of the disease, rather than what most people think of what palliative care here is in down south. So I've been focusing on doing a lot of education initially with physicians and nurses. That way they can truly understand what palliative care is. And my new passion is really doing community outreach like this to educate folks like you guys about really what is palliative care and why is it important to do advanced care planning. Okay, so let's see. So what is palliative medicine? So palliative medicine is an approach to medical care for people with serious illness. Though palliative care was initially created for cancer patients about 50 years ago in Europe, initially in England, and it became more popular in the US probably in the early 2000s, where palliative care was getting involved in helping with pain and symptom management, but mainly with the end of life discussion and goals of care discussion. But it has revolved from that, where majority of palliative care, especially academic centers, have palliative care clinics, and they go hand in hand with the oncology clinics, and they help patients with whatever symptom burden those cancer patients may have. The main focus in palliative care is providing patients and their families with relief from symptom and pain and the stress of the serious illness, because we feel like when you have significant symptom burden and there's a lot of stressors, it's hard to have a good quality of life. And that can be done at any stage of the disease process. And that's really what I try to educate people, that palliative care is not something we get involved only when people have advanced cancer, stage 4 cancer, or metastatic cancer. It could be in stage 1 if patients have significant symptom burden, whether it is from the cancer or from the treatment. And it provides really a team approach where we have doctors, nurses, nurse practitioners. Though we don't have it here on Northside, and some of the other hospitals I've worked and trained, A palliative care team will include a chaplain, a social worker, because you really have to address the spiritual stressors of being a cancer patient, the emotional stress of being a cancer patient. So really entails a very diverse group of interdisciplinary team communicating and taking care of the patient. And like I said before, it is appropriate at any age and any stage of a serious illness. So part of my training, we do palliative care even in pediatric patients who have cancer. So palliative care have a role in every age and stage, depending on what the need of that patient is. So this is a nice diagram to show how palliative care can help. As you can see, from the moment a patient is diagnosed, the main initial step is curative, to cure whatever the cancer is. And initially, the palliative care may not have much role, depending on whatever the symptom burden is. But as people are going through second line, third line treatment, they may start developing symptom. And that symptom could be nausea, it could be anorexia, it could be depression, insomnia, constipation. So there's so many symptoms beside pain that can be addressed with palliative care involvement. And unfortunately, in some patients, they may not be able to achieve curative stage. So we may get involved, our role may change where it's not just for symptom management, then we may be talking about goals of care or hospice. So this kind of summarizes what are the different domains of palliative care. Like I mentioned a few slides, the physical part is kind of the obvious one, which is the physical pain, the nausea, the vomiting, the diarrhea, the constipation. But a lot of other fields don't focus on what affects the patient, the rest of the other stuff that can still affect the quality of life of the patient. And that includes the spiritual part of being a cancer patient, the guilt, remorse, fear of, what's going to happen to me, what's going to happen to my loved one, or the emotional aspect of it. People who never had a depression or anxiety, all of a sudden are going to have adjustment disorders, adjusting to new quality of life, to new functional status, to not being able to work, frustration, hopelessness. And those are the things we address. And the social aspect, which a lot of time, especially as physicians, don't spend a lot of time, is the financial burden. How is it affecting the family, the children, the spouse of those patients who are going through treatment? So really, what constitutes suffering? What affects quality of life? The physical part, we already talked about: pain, symptom management, functional status. Someone who never needed to use a cane or a walker now needs a cane, now spending more time sitting or sleeping. Psychological, the depression, anxiety. We talked about social, the family support or lack of it. What life looks like at home. Spiritual support, what kind of support are patients getting from the community, from the church, from their faith-based, and cultural. And this is the one I am very passionate about, because initially when I moved to Georgia, I worked at Grady, and I have dealt with so many different cultures, and I pride on really trying to understand people's cultures and respecting it and understanding rituals and not trying to impose what we feel should be the norm. And then addressing people's fears. People a lot of times don't want to complete advanced care planning because that means I'm dying. That means I have to talk about the what ifs. So really talking about hopes and fears, and grief. And the grief could be talking to the patient themselves or their loved ones, talking about how do we anticipate loss and how do we prepare for it. So those are really all the different aspects what palliative care covers, whether it is in the hospital or in the clinic setting. So I'm not going to spend too much time here, but as you can see, palliative care has a lot of impact in a hospital setting, because if we get involved early enough in a patient, especially coming with pain, we can, lower how long they can stay in a hospital. That means they can get back to getting their treatment, whether it is chemo or radiation, sooner. By addressing advanced directive and making sure the patient is naming the right person to make decision for them and completing one. Identifying treatment goals, because sometimes one of the things I notice is that patients feel like they want to talk to their oncologist about what's next, or maybe not wanting the next step, but they feel like they're disappointing their oncologist by talking to it. So really encouraging the patient and family to have honest conversation and ask very specific questions. What am I going to benefit from a treatment? What does this mean for me? What is it going to add for me? So really empowering patients. And there are a lot of studies that were done that when palliative care is involved earlier, people actually live longer. And the reason people live longer is not we have any specific magic, is because we try our best to improve their symptom burden and try to prevent from them being in a hospital too long, and avoiding going to the ER too much, avoiding rehospitalization, especially if it comes from symptom burden, and sometimes reducing unnecessary tests if patients' goals are different. So this is a really great research that was done in 2010 in New England Journal of Medicine, and it was repeated again a few years later. And the data was so powerful, actually, they did not need to complete the research. What they did was they followed 151 lung cancer patients who have advanced cancer, and they randomized them to usual care, which is they would just only see their oncologist, versus they will see the oncologist, whether it is surgical oncology, radiation oncology, medical oncology, but palliative care got involved from the moment the patient was diagnosed. What they saw was that compared to the usual care only patients, the patients who were in palliative care were observed to have significant improvement in quality of life. They were less depressed because they talked about the disease and they talked about the trajectory. They know what to anticipate. And they had fewer burdensome treatment because those symptom burdens were addressed early enough. And surprisingly, they had an improved survival by 11 weeks compared to the other usual care. So a lot of times when I get involved in the hospital and I call the family and introduce myself, one, most people don't know what palliative care is, so I have to explain what it is. But those who know, the first thing they will say to me is that, oh no, I'm not interested in hospice. But palliative care is not hospice. Palliative care, you can still be saying I want palliative care and still get chemo, still get radiation, and it's covered under traditional insurance or Medicare, and you can still opt for aggressive treatment. All palliative care's goal is to make sure as patients are undergoing treatment, they have quality of life and addressing those things we already talked about. What hospice care is different. When people opt for hospice is when the doctor is saying, based on where things are going, based on the trajectory of your disease, your life expectancy is 6 months or less. That's when hospice care comes in. Hospice care is covered under Medicare, but it also covered under most traditional insurances as well. And in hospice, the goal is different. We're not doing aggressive treatment in terms of to prolong life. We do aggressive symptom management to improve quality of life, whether that symptom could be agitation, anxiety, pain. So those are really two different routes, and there's some similarities, as you can see in the middle, but completely different things. People continue to see their doctors when they are opting for palliative care, continue to live their life. And even in hospice care, some people can still be functional and say, I just don't want to get any more chemo, and still be on hospice. Hospice does not mean people have to go to a facility or you have to be bedbound. It just depends on what people's choices are, depending on where they are with the disease. So I'm going to spend most of the time from about advanced care planning, which this the whole conversation and talk is today. So there are different ways people look at advanced care planning. It could be a living will. People can complete with their lawyer, can get notarized, or people can just choose to do a durable power of attorney. So a durable power of attorney is patients saying that, God forbid, if something happens to me and if I'm not able to communicate, this is a person I want to communicate for me. So the durable power of attorney, if you're just completing that form, it doesn't tell us anything about your treatment preference. And I will talk about what that means. So Georgia is great that they have their own standardized Georgia Advanced Directive, and I'll go over it in detail soon. That one, what I like about it is that you don't have to pay a lawyer. You don't need for it to be notarized. All you need is 2 witnesses to sign it while you are completing it, and that's it. And that's what makes it very easy to complete. What it does is that it really enhances patient and family to really talk about the illness, because a lot of times people have this feeling like, if I talk about it, then I'm telling my families that at some point I'm gonna die and I have to face it. But the way I live my life is that we all gonna die at some point, especially, to be honest with you, since COVID started, I always have communicated with my husband what my wishes were, but knowing how much risk I am putting myself and being in the ICU taking care of COVID patient, I completed an advanced directive. I sat down with my husband, told him what my wishes are, what are things I'm okay with, what are things I'm not okay with if I'm not able to communicate. I knew who should be the backup person if, God forbid, something happened to my husband, or if he had a hard time making those decisions. So really has nothing to do with age. I don't have any medical problems, but you don't know what could happen in life. And I never want to put that burden on my loved ones, wondering what my wishes are. So it defines the priorities for end of life care. And it really gives the family a plan. And what I tell families and patients, especially my patients, when I used to have clinic, is that they ask me, but I know what my family want. I don't need to complete it. But what an advanced directive does is that it gives your family a gift. The gift is that it takes away the burden of them wondering what you want, especially if you have multiple children and if they're not going to agree on something. If it's written down, it really is not them making the decision anymore. They're just relaying your message because you cannot speak, and they're just on your behalf. It's written down, and they just relay the message. And to me, there's nothing more empowering than, even at a moment when you're not able to speak, you still telling us, the physicians and nurses, how we should care for you. And there are different parts of the advanced care planning. You can address whether you want artificial nutrition, meaning, do you want a feeding tube? Do you want IV fluid? Do you want a feeding tube through the nose or not? What about through the belly? You can make it as detailed as you want. And the other part, and the part I emphasize a lot, is that, God forbid, if something happens, if your heart was to stop, do you want doctors to do CPR or not? Do you want to be on a ventilator or not? And you can be very specific depending on what your disease process looks like. And I'm going to talk more about it because a lot of people, even sometimes in a hospital, have a miss about what DNR is. I do a lot of education for ICU nurses and oncology nurses by giving them scenarios that do not resuscitate does not mean do not treat. Somebody can be a DNR and they can still be moved to the ICU. They can still be put on some life support medication that are non-invasive. They can still be placed on masks, some that are called BiPAP, to help them breathe. I know a lot of times the community feels like they don't want to tell us they are DNR because they have heard stories that the moment you say I'm DNR, people are not going to do anything for you. And I want to make sure that's not the case, because you can still say, I want to be DNR. DNR only means do not pump on my chest if my heart stops, if I lose pulse. That's it. That's it. Everything else should not change. If somebody comes with pneumonia, they can still be intubated if that's what they want, meaning placed on a ventilator. They can still get IV antibiotic. They can still get everything else. They're just saying, I'm just setting some limitation depending on where I am in my life, in my disease process. I don't know if I want to take that risk of you doing CPR and not having a guarantee if I'm going to come back to the same person or if I'm going to have the same quality of life. That's really what that means. So this is the other part I'm very passionate about, and I'm going to tell you why. One, a lot of times I'm always applauding people who have completed advanced directive in their 40s, in their 50s. But what happened is that sometimes people present their advanced directive from 20 years ago. The thing is that none of us will have the same medical problem 20 years later. Most people are sicker, they have new diagnosis. So as much as I applaud people who complete advanced directive, I also encourage people to review your advanced directive every few years to see, have your experience make you think differently than you did 10 years ago, 20 years ago, or sometimes those people who completed the advanced directive and who may have named a certain person to be their, the decision maker, that person may not be alive anymore. So really, it's important to review it every few years. So in the state of Georgia, this is how the hierarchy goes in terms of who can make decision for you if you have not completed an advanced directive. So the first one is, if you complete an advanced directive, then that person is the first. It could be a friend. Some people may have chosen a good friend of theirs, their best friends for 30 years over their spouse. Then it doesn't matter. Then that's the person we're going to communicate with. But if you don't have an advanced directive, if a person is married, their decision maker is a spouse. And the spouse is still going to be a decision maker even if you are separated but not divorced. And people get shocked by that. The law is the law. If you're not divorced, we still have to go search for the spouse, even if you've been estranged for years, because we have to do due diligence by the order the Georgia statute tells us. And after a spouse are children. But the problem sometimes with children is that if people have 4 or 5 children, and you haven't completed an advanced directive, I have a responsibility to reach out to all of your children to make sure they are on the same page if something was to happen to you and you're not able to communicate. And I can tell you stories of fights and people screaming at each other, 2 people maybe on the same side, the other may not, and trying to bring them in, trying to make them think of what that patient would have wanted. And after, if that person doesn't have children, then parents become next in line. And again, after that are siblings, the same thing. If a person have multiple siblings, we have to reach out to all the siblings. And the last one is a legal guardian. So we covered most of this in terms of what the Georgia Advanced Directive includes. It includes the part where what your preferences are for treatment. And I'm gonna go over this in detail. And it has an area, it asks you if you want artificial nutrition or not, and in terms of your treatment preference. And then you can even write in, some people, let's say, who have chronic kidney disease may say, I don't want dialysis, and you can write that out. Some people may say, I don't want blood transfusion, and you can write those specific things out in your advanced directive. Okay, so now I'm gonna switch to the Georgia Advanced Directive. Let me see. Okay, there it is. So it has a total of 16 pages, and it can, when we first give the package to most of the patients we get involved with, it can feel very overwhelming because the wording is not very easy to understand. So if you end up seeing myself or one of my colleagues in the 3 campuses, we do our best to educate you, but I'm going to focus on few pages that are the most important. So this is the part that tells you about your right to decide, what advanced directive is. And it really gives you, you can read through it and it actually walks you through what you need to do. But the part that I'm going to focus on is this one. You know, first thing, you have to have your name, your date of birth, and then it asks you who is going to be your healthcare agent, meaning who are the people who are going to make decision for you if you're not able to decide. And this is where you put the first in line. It could, whoever that is, the first person, their address, and their number. Okay. And then you always recommend a backup agent, because something can happen to that person, or that person can be out of town and we cannot reach them. And even sometimes when patients tell me, I'm not sure if I want to be a DNR or full code, or I don't know what treatment option, I say, that's okay. At least complete who should be a decision maker, especially in those patients who are not married, patients who don't have any family in the state, patients who the person who knows them the best is their neighbor or the friend, but that friend can know you the best. It would not matter based on the Georgia law. If you have not named them in either in durable power of attorney or in the Georgia Advanced Directive, we cannot even communicate or share any medical information with that friend. And that friend cannot make any decision for you unless you complete this. So this is the first most important part. And then we're going to go to the next part. Most people, I tell them it's up to you if you want to fill out the organ donation. Most people do not. Now, this is the second part that's really important about the treatment preference. And the treatment preference has 2 sections. So the first section asks you, so the first part says, Part 2 would be effective only if you are unable to communicate. And that's really what I tell my patients. So my patients sometimes would bring the advanced directive, and I said, great, we're going to have a copy, but it really doesn't matter to me right now, because as long as you are able to communicate with me, I'm still going to communicate with you. This advanced directive only applies if you're not able to communicate with me. And at any point, if you're communicating with me, you can change your mind. It doesn't matter what the advanced directive may say, you can change your mind. So that's the key. This only gets enacted if the patient is not able to communicate. So most people, what they end up choosing is they initial the section 6, the condition. The conditions are 2, and most people end up initialing both. One says, if I am in a terminal condition, which means I have an incurable or irreversible condition that will result in my death in a relatively short period of time. And then the other one is a state of permanent unconsciousness, which means I am in incurable or irreversible condition in which I'm not aware of myself or my environment, and I show no behavioral response to my environment. Now you go to section 7. The reason I am emphasizing this is that a lot of times people do not initial the first 2 parts, or they initial the section 6 and then they don't do anything. And that makes it invalid for treatment preference. So section 7 then asks you options. There's 3 options. So based on the top part, what would you like the doctors to do? So the 3 options are, do you want to try to extend my life as long as possible using all medication, machines, or other procedures that in reasonable medical judgment could keep me alive? If I'm unable to take nutrition or fluids by mouth, then I want to receive nutrition or fluids. So what this means, just to make it simple, this is saying that even if I'm in a terminal condition, even if I'm unconscious state, I want you to do everything. I want you to continue to keep me alive as long as possible. That's what choosing A means. Choosing B means allow my natural death to occur. I do not want any medication, machines, or other medical procedures in reasonable medical judgment could keep me alive, but cannot cure me. I do not want to receive nutrition or fluids by tube or other medical means except as needed to provide pain medication. So this could mean a patient who may have advanced disease, who all of a sudden may have been already on a ventilator, and saying that, and the doctors may be saying to the family, we are having a hard time taking your loved one off of the ventilator. When I'm reading this, what this patient is saying is, I don't want to live on machines. If it's not going to give me a quality of life, I don't want to do that. So that's what it means. Or it could also mean if someone already have a very advanced disease, advanced cancer, it could be advanced CHF, advanced COPD, we know that those diseases eventually would progress. So in that person, this could also mean do not resuscitate me if my heart stops. Because what we know is that if someone gets that sick, their heart stops, the chance of coming back to a good quality of life is very low. So about 60 to 70% of patients who complete advanced directive end up picking B. And then there is C. C is kind of very different. C is saying, I don't want medication, I don't want machines, I don't want other medical procedures that in reasonable medical judgment could keep me alive but not can cure me. And this is saying that I don't want you to put me on a machine from the beginning. I don't want you to intubate me, meaning don't put me on a ventilator, don't do CPR on me, but they can also pick one of this. Do they want to have a feeding tube or not? Do they want fluid toward end of life or not? So you can pick this. So it can get very confusing, but I always encourage people that it has to make sense. So what I've seen, and this is what I don't like, this is the only part I don't like about the Georgia Advanced Directive, is that people will pick, I do not want any medications or machines or procedure that in reasonable medical judgment could keep me alive but not can cure me. But then they will pick, if I need assistance to breathe, I want to have ventilator used. Sometimes it can be very contraindication, because contradicting it, if you have a COPD, advanced COPD, or you have advanced lung cancer where extensive metastasis all over your lung, C is telling us you want to be kept comfortable and don't want to go through machines. But when you're picking, I want to be on a ventilator, it kind of does not make sense. So that's why a lot of times I sit down and I go over this with my patients, depending on what their disease is. Because one may apply to some person and the other may not, depending on what you have. And then the other parts, they talk about if you want the person to be your guardian or not. The last part, so you can do all that work on the Georgia Advanced Directive, but it means nothing if you don't have it signed by the patient and you need 2 witnesses. And the thing about the 2 witnesses is that the witnesses cannot be healthcare providers. The witnesses cannot be the 2 people you chose to be your decision makers, which are the 2, the first line healthcare and the backup agent. So as long as this is signed and dated, and just like it says here, it does not need to be notarized. And that's it, you're done. I always encourage people to keep the original and have a couple of copies given to, especially to those 2 people you named as your decision makers. And if you are still seeing your oncologist or your primary care doctor regularly, give them a copy and you're done. And the way I think of it is that you do it once, hopefully you don't have to think about it for a few years. And the analogy I give to a lot of people is that, like having car insurance. I don't want to pay for car insurance in Georgia. It's expensive, but I have to do it. I have no choice. If you ask me what's the details in my insurance, I can't tell you. But when I first started, I got it done. I know the general scheme of like how much coverage I get for if I get into an accident, if I hit someone or if someone hits me, and I review it every few years to make sure it makes sense based on the kind of car I'm driving, but that's it. And then I put it away. And that's really how I think of Advanced Directive. You do it and you hope you don't have to use it anytime soon. And it's not a conversation you need to have again and again once you get it done. Okay, I think I have spoken enough, and I want to make sure that I give some time for people to ask questions, whether it is about palliative care or advanced directive, about DNR, or any other question you guys may have.
Thank you, Dr. Sayed. That was a very interesting and in-depth conversation about advanced directives, I think helpful to a lot of people. I'm going to invite everyone to enter some questions into the group chat. And I'm going to jump to this one first. A participant shares, my widowed mother is now incapacitated and never appointed a healthcare power of attorney. What happens if my siblings and I cannot agree on a plan of care?
That is a great question. I actually should have included it. This is the reason I encourage people to complete advanced directive early. In order to complete advanced directive, the patient cannot have dementia. You can have mild dementia, but the patient has to have capacity to complete it and understand what they're completing. So in this case, unfortunately, the siblings have to come together and for the best of the patient, decide what's best for the patient. But legally, there's nothing they can do, because that patient, because of, I'm assuming how advanced their dementia is, they will not be able to complete an advanced directive or a durable power of attorney.
And I think that kind of speaks to the importance of completing this paperwork prior to a health crisis or a traumatic event. Okay, another question we got is, since advanced directives are not a legal document, does the healthcare agent have to honor the wishes of the patient?
Good questions. So two questions. So healthcare documents are legal documents, but there are a portion actually in the advanced directive. I'm not sure if the Georgia one does it. You can choose to say that, you can say specifically, you can write it out and say, I want my my decision makers or my healthcare power of attorney to follow my my direction. Because in the state of Georgia, the way it's written, if you don't specify that, the decision makers actually can change whatever you have chosen. And I've seen it multiple times. For example, a patient may have chosen, if I have a terminal condition, please allow my natural death. And then a loved one or their children may say, no, we don't think that's terminal. We still want you to do everything. And because the state of Georgia is more conservative when it comes to advanced directive, and it really gives power to your healthcare proxy. And that's why I really encourage people, you have to think wisely, who should be a decision maker? You know, is this because the decision maker has to act on your behalf, because we are all human. And a lot of times, especially for a lot of children, it's hard to lose their parents and their loved one. And sometimes you may not realize it, but unconsciously you start making decision of what you want for your parent or for your loved one, rather than what your loved one would want for themselves. So you can state it to say, I don't want my healthcare proxies to make any changes to my decisions.
Okay, yeah, the power of the healthcare power of attorney, like you said, choose wisely.
Yes.
And this next question, can you talk a little bit about the differences between a durable power of attorney versus a non-durable power of attorney?
Okay, so I think it's more interchangeable. Sometimes, depending on if you're just completing the durable power of attorney form, depending on which one you're completing, you can pick that durable power of attorney to be for financial and health care. If you're completing the Georgia Advanced Directive, that's only for healthcare, because I have seen people bring forms sometimes and say, oh, this loved one, you know, oh, I'm their healthcare durable power of attorney. But when we read the details of the form, the way that patient completed it is only for financial. So people can choose durable power of attorney to be for financial and healthcare and specify it. But if you're completing the Georgia Advanced Directive, that's only for healthcare.
Okay, Thank you. And this is a question a participant has. Where can I get a copy of these advanced directives? And if someone is in healthy condition without any kind of life changes like a marriage or a divorce, how often should people be reviewing their advanced directives with their healthcare power of attorney?
I would say every 5 to 10 years. Because even if you may not have in those 10 years, you may not have any changes in your health, but you may have experienced something, meaning you may have experienced the death of a loved one. You may have experienced seeing a friend go through difficult time through cancer treatment, and it may have changed your view how you want to be cared for. So I do encourage people to review it, every 5 to 10 years, because I think as we all mature and as we all get older, I think our views about the world, our views about everything changes. So it's really important not to just complete it once and just put it away in a bank vault or whatever. It's important to review it from time to time. And sometimes you may have a great relationship with the person you chose, and 10 years down the road, you may not. So I think it's important to review it, even if you don't have a lot of changes in your health. And in terms of where you can find it, you can actually go to, and maybe you can send out the email at the end. You can go to northside.com/advanced hyphen directives. And you can find it from there and print it out, and you can complete it.
Okay, and I think this is something you just mentioned, the importance of not keeping it in a bank vault or a safety deposit box. These are probably going to be something you want easy access to, and for your healthcare power of attorney as well, right?
Yes. Yes.
Okay. And so I think we're going to jump to a couple palliative care questions.
Okay.
One of the participants asked, what is the difference between palliative and hospice care in regards to pain management?
Okay. Good question. So that depends on a lot of times life expectancy of the patient. So if the patient has a life expectancy of 6 months or less, or that patient says, I no longer want to continue curable treatment or treatment that's just prolonging my life, whether it is chemo or radiation or immunotherapy, but I just want to have a quality of life where I don't want to go to see the doctors. I just want one person to manage my pain. Hospice may be a good option for them, even from home. But what palliative care does is you can still continue to see all your doctors, and you can still get your symptom burden treated. The only limitation sometimes when we are doing palliative care is, for example, if the patient is having significant pain where it's hard to control it, and we are going up on the medication, and all of a sudden it's affecting the blood pressure, it's affecting how they function, we're going to be limited because we have to have a balance. What I always tell my patient is that I can't take your pain away. It would be impossible to take most patients' pain away, knowing the kind of cancer they have. My role as a palliative care physician is to make you functional enough for you to continue your treatment. Meaning we have to come to an agreement to some level of pain that's tolerable. That way you can continue to go see your doctors and continue to live your life. It's kind of the same in hospice, but in hospice, for example, if you're having severe pain, but all of a sudden is also affecting your blood pressure, they're not going to worry too much about that because the intent and goal is different. The goal is to be as aggressive as you need to be to control pain, even if it may affect your blood pressure and other parts, even if it means you may be dizzy and you may spend more time sleeping because of the medication. Because in hospice, we're saying you don't have much time left. So we want to make sure that you're not suffering through that process.
Okay, and this is another palliative care related question. Is it possible to qualify for outpatient palliative care services? And does Medicare or private insurances generally cover this?
Good question. Yes. most patients, if you have a serious illness, meaning in cancer patients, yes, you will qualify for palliative care. I'm going to be honest with you, the biggest problem we have in Georgia is that there are not enough outpatient clinic palliative cares. Right now, I am working hard to try to create a palliative care clinic for Northside, but I don't anticipate that happening for another 2 years. And with everything that has happened with COVID, it really has, set us back more. So depending on the need of the patient, I have referred patients to Emory. I have referred patients to Wellstar. If they have Kaiser, Kaiser has a palliative care clinic. But for some, there are actually a lot of agencies. Just like there are hospice agencies, there are palliative care agencies, and Medicare pays for that. It's just like having a co-payment, like you visiting your doctor, but they actually come to you. They come to the house, they come and check on you about once a month, and they will communicate with your cancer doctor or your primary care doctor in terms of what your pain medication should be, what adjustments should be made. So most people who have cancer will qualify for palliative care services.
Okay, and so what would be the next step if someone feels like they're eligible and could benefit from palliative care services? Who should they contact? Would it be going through their insurance company or where they were treated for their cancer?
Yeah, so the easiest way is where they have been treated for their cancer. So they reach out to their oncologist and ask them to set up a referral sent out. And depending on how functional they are and how they want to do it, if they want to be in academic center type of, a very well-rounded palliative care, then I always recommend doing it through the outpatient clinics, which are the Emory and Wellstar. But if they feel like they're already seeing so many doctors and they don't want to, they can ask their oncologist, one or two ways. Can you send referral to Emory Palliative Care? Can you send referral to, depending on where they live, Wellstar Palliative Care? Or say, can you send referral to one of the palliative care agencies? So if it is the agencies, then the agencies will come to you.
Okay, great. And this is shifting a little bit back to the advanced directives. A participant shares, every time my mother is admitted to the hospital, we have to sign a new DNR. Is there a general DNR form that we could have signed that just kind of goes with her?
I am with you. I wish they were. I'm from New Jersey and they were in New Jersey, but here in Georgia, unfortunately, every time you come to the hospital, you have to sign it again. And it's very frustrating because the reason it's frustrating for me is there's sometimes, depending on who's admitting your mother, if they never asked, your mother end up being full code. Unless from the beginning you are, you happen to be with her and say, I just want you to know that my mother is DNR. So I see that a lot and it's very frustrating. And unfortunately, I don't see that changing anytime soon because that's just how, whenever you do a DNR in the hospital, it only applies for that hospitalization.
Okay. Yeah, I can see that adds to the paperwork for folks, but is an important one for sure to have that conversation about. Another participant shares, I'm having a hard time encouraging a family member to complete advanced directives. Is there someone on the healthcare team I could reach out to that would be an appropriate resource to have this discussion?
So I know I was talking to some of the oncology social workers and this oncology psychology, and they said they do have services where they help patients at least go over it and help them complete it. But I am so glad that person asked, because one of the things I want to do is that I'm going to ask my clinical managers send multiple copies of this book. And the reason I like this book is I don't benefit anything from this book, but it talks everything I talked about today, but in a very easy way. And it's written by a chaplain, a hospital chaplain who has taken care of so many patients and what he has seen. And the name of the book is called Hard Choices for Loving People. And it talks about CPR, feeding tubes. It talks about palliative care, comfort measures. It talks about dialysis. It talks about dementia. And I really think it's a nice reading and really helps people understand what is the best way to go in terms of completing it. But in terms of from our point, from palliative care, unless you happen to be in a hospital, we won't be able to help you. But we are also working in a telehealth plan. I don't think it's going to happen anytime soon, but our hope is if we can establish telehealth, at least either once or twice a week, we will have sessions for oncology patients. And part of it is basically guiding patients how to complete advanced care directives and answer questions they may have about it. But I don't see that coming anytime soon.
Okay. I think we're wrapping up the questions. If anybody else has some last minute questions, please feel free to enter them into the chat box. Otherwise, I do just want to remind folks that Cancer Support Community Atlanta continues to offer virtual oncology support services like these education programs. So you can visit us at cscatlanta.org for all of those. And the recording of this program today will also go up on our website if anyone wants to share that or reference it again. As we wrap up, Dr. Sayed, do you have any closing remarks you'd like to share?
Yeah, so the one thing I will say that I try to be accessible to a lot of patients, even if I'm not taking care of patients. So if any of you have questions today after you go home and you talk to your loved one, or you share this with your neighbors and friends and people have questions, I am happy for you to share my Northside email with them, and they can ask me questions about whether it is about palliative care, how to have access for palliative care in outpatient setting, or any more questions you guys may have about advanced directive and advanced care planning.
All right, great. Thank you so much. You're such a knowledgeable resource for Northside and our community. We're so appreciative for sharing your time and expertise today. We're getting a lot of thanks in the chat box. So thank you, everyone. Everyone take care, and we hope to see you guys again soon.
Thank you so much. Thank you for having me.
Thank you. Bye, everyone.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.